Good morning, ladies and gentlemen. It's an honor to be representing all my colleagues from yesterday. The 21 dentists that did the presentation yesterday to me were all finalists. And the 6 of us today, I'm sure we will be representing all of you. So what I would like to do today is to share my experience in full arch rehabilitation over Zirconia, monolithic. I come from the south of Spain, and the first thing is to check what is our challenge on full X. Do not forget that these patients, they haven't been to the dentist a lot. We need to recover aesthetics, functionality. So we have a lot of things to consider. So a good plan, a good planification, digital planification, it is really important. My challenge is that I work in Spain, but once a month I go to the UK just to deliver this type of treatment. For this reason, thanks to digital dentistry, we can approach this situation. But because we have to deliver long-term solutions, because we cannot forget that, the patients, they want teeth. They don't want implants. So we need to make sure that with the teeth that we are delivering, they are properly done. For this reason, what I want to do is share my full arches since 2017. These guys on the screen, they were all done fully digital, with the same dentist, which is myself, and with the same technician. So out of 148 arches, we just had 11 fractures, which to me is a remarkable answer. The truth as well is that we know why the fracture happens, which is really good. 5 of them were because of my fault, because I wasn't familiar with the digital protocol to start with, because I didn't tighten enough the multi-unit, and then I delivered the impression wrongly. I gave the wrong information to the lab. So when I received the final zirconia, the passivity of the arch wasn't right. So the zirconia, you can love it or you can hate it. But zirconia is not flexible. So as soon as there is a tension or a problem, it will break. So on the other hand, the other fractures, they happen because of my technician fault. Because in anterior area, they try to individualize. Sometimes in anterior area, they didn't leave enough room for the zirconia. So if we don't have enough zirconia, it can break. But we identify the problem, and we are working on it to reduce these fractures. And one of them was a very atrophic maxillar, very big block of zirconia, and it broke. We did the test, everything was right, but it just broke. So for this reason, sometimes for those cases, we put titanium, and then on top, we cement zirconia. For every single case in my clinic at Crooke Laguna in Spain, from many years ago, we've been doing this step for every single patient. Some patients are more difficult than others, it is true, but we treat all the same. So the step 1 is collecting all the data to take some photos, intraoral scanner, and a CBCT. Once we have that, we put all together, and with our technician, we will design the project for the patient. So once we have the project done, the surgical guide, the plan where the teeth are going to be, then we go to step number 2, which is the surgery, and then after that, we will mild machine a PMMA full arch for the patient as an immediate loading. On the step number 3, the patient will be 3 months with this PMMA temporary teeth, and during 3 months after that, the step number 3 will come to do the final smile. So this step, to me, is the most important, because in here, if we don't do this right, we will end up having a lot of problems for our patient. So when we go to the photo, I asked my case today, his name is Daniel, heavy smoker. He has to travel a lot. And the problem for him is that he's very scared. He heard about bone grafting and things like that. And he heard that you need so many appointments to fix his teeth. And I said to him, OK, your teeth are a mess. We need to do an all-on-6, upper and bottom, and we need to do it fast. So give me your better smile, Daniel. And Daniel, this is the smile that he gives me, because the bridge is moving, everything. He's so ashamed of his appearance. The good thing is that from real picture, we can go to an STL. So we have a lot of information already. We give this to the lab, and then we start to rectify our plan, improving the functionality and then the aesthetics. But then as well, when we're planning the implants, we cannot forget, as Gallucci described, the 3D position of the implant. apicocoronal, the implant needs to be deep enough. Mesial distal, we need to leave room between implants, between implant and tooth. And mainly, as well, buccal, lingual. Some areas that we don't have enough room, we need to respect the tissues. Otherwise, we end up like this. And this position will be the result of a bad prosthesis. So this is not the patient's fault, it's our fault. At the same time, we cannot deliver non-parallel implants. So nowadays, with the multiple programs that we have to make implants parallel, how we can deliver this type of teeth. And then if it breaks, then it's the technician's fault. No, I'm sorry, it's our fault, okay? So for this reason, Artugate is a good tool to me, because I can combine everything. I take the photos for the patient. My designer designed the teeth, so I want to have these teeth into my implant design program, because like this, I can guide my implants through the teeth, not the other way around. Once I have that, I will get the STL, and then we'll go to Artugate. I can remove Daniel's teeth, and I can place his design. And once I have that, then I'm going to decide where I place my implants, okay? In this top area, he didn't want to have a sinus lift, and then I said, okay, we will do one extension on each side, and then we will finish Daniel. Like this will be quickly. But then we have the project already. And also after that, we will check our 3D position planning. With Artugate as well, we can choose the multi-unit abutment that we're going to use. And it's fantastic, because before the surgery, we're going to have the implants and the multi-unit abutment. The same thing happened at the bottom. We can remove Daniel's teeth, place the project, and make sure that the implants are guided through the teeth, not the other way around. Also, making sure that we don't damage any nerve structure, and if we know that we leave the implant position in the right place, the treatment will last, because that's what we're looking for, a treatment that it will last. So step number 2, we go to the surgery. At this stage, we can decide if it's going to be a FP1 prosthesis or an FP2 as a misclassification. So we can call Daniel, and I said, Daniel, look, we lost a lot of gamma bone already, so we're going to end up into a type 2 prosthesis. So we know, we haven't touched him yet, but we know a lot of things, that how the treatment is going to go, what he can expect. So after we design the implants, with Artugate, we can export the project of the 6 implants with the scan bodies, and then design the guide. We left a molar as a support. It's a gum-supported guided, and also we'll do some anchor piece in the front to give stability. At the bottom, the canines were kind of solid, so we have 2 molars at the back and 2 canines at the bottom. Like this, we can make real the implant position that we designed before. Then, in every single case, thanks to any rich surgical kit, we can collect bone and then keep the alveolar situation. And every tooth that we remove, we clean, we place our implants, and then we fill everything up. So this is Daniel after the surgery. The surgery lasts 1 hour and a half, 2 hours, everything guided, and these are the scan bodies that we're going to do for his impression. The same thing happened at the bottom, minimum invasive treatment, and everything is nice and tidy to take the impression and order the final. So this is 24 hours later. A PMMA, ultra-polished material that he's going to wear for 3 months. In the top area, we left with no extension yet, because I didn't want to have an extension with PMMA, because otherwise it might break. So 80% of the treatment, it is completed. So the promise that we did to this patient, it is completed. So we came from initial treatment to planning and to final smile. But if we do all that and the structure is not passive, for PMMA or for Zirconia, it will be a failure. For this reason, I work with a lab called Medical Fit, and we have a very precise passive test. Step number 1, which is called Medical Fit 1, we will take the impression of the implants, and because it's an edentulous patient, we will have a deviation. So in order to rectify the deviation from the STL, we can take the patient and take a CBCT with the scan bodies, and we send the CBCT and the STL file, and they will superpose. And like this, they can rectify the error. Like this, the teeth will be passive. If for some reason we don't have a CBCT in the practice, or we don't want to do more radiation onto the patient, what they provide us is a special tray. It's called Medical Fit 2. Basically, what we do is a pickup of the implants. We put analogs, and with your same intraoral scanner, you can take an impression and send it to the lab instantly. You don't need to post this tray. So like this, again, we will have a passive test. Once the teeth is passive, we're going to go slightly deeper. Are we going to use T-base over this multi-unit prosthesis? No. Because in the past we had a lot of problems. They used to de-cement from the teeth, especially from the PMMA. They have to give you a lot of width into the emergency profile, and we want to respect the tissues. So for this reason, this lab increased the height of the multi-unit, making a longer screw and avoiding the failure or the fracture in the connection, because the problem was that the base was too thin. So this is the reason why they increased that. So in the PMMA and in the Zirconia, we don't use regular connection. We use this type of connection, a modified. If we analyze the finite elements without the modification, you will see that it has a stress. It will have tension, so this will break. In the other hand, when we modify it, then we release the tension up to 6 times. So none of the fractures that I had happened on the connection. It always happened in the middle, because it was an error of the impression or an error of not leaving enough zirconia. So this is the aspect, how the tension release over the modified base. If we go slightly deeper into the multi-unit T-base, when you go from temporary T-base to a final, first of all, it's shorter. And secondly, it's wider. So 2 bad things, because you need the teeth to be cemented on top of that, and you need to have room for the gum. So in anterior area, it's really difficult to work with these T-bases. And you leave less room for the zirconia, because you need room for the cement and the T-base. So to me, it's not an option if the modified base, it works, okay? The only advantage is that the fitting, it is slightly better, so you will have less leaking of bacteria, okay? But that's the only thing. But because we use multi-units from 2 or 3 millimeters, everything happens above the implant area. When we see the prosthesis without the T-base, then we have better things, because we screw 6 implants at the same time, and it's 1 block, and you know that nothing is not right, okay? You don't depend on your lab technician to check if the T-base is correctly cemented, or you know that all the implants are joined together, and you have more room for the zirconia. So for example, if we work in a FP1 and the lateral implants that has to be placed in this area, in this case, it's really difficult. First of all, the platform is nearly like the central incisor. And in this area, it is very difficult to make a titanium bar and then cement zirconia, okay? The reason why we want to work with zirconia is because not every patient can afford to pay a good ceramist, and not every clinic has an artist in the clinic. So we are moving to digital era, and this is the way to work with. I know that zirconia has limitations, but we can get the most from it, okay? So in this case, to me, working with T-base is a problem. But this is not working just for me. From 2016, they've been studying this protocol, okay? So apart from my experience, which is working, this has been tested to make sure that the passivity of the teeth is correct. So we go back to Daniel. We unscrew everything, and we need to see this sort of situation, because what we want is to last, the treatment to last, because we have respect the 3D situation. We have done a nice ultra-polished temporary, then the gum, it is like this. If you go to the bottom, even better, because we have less amount of gum, and it's working fantastic with the situation. So we decided to make a second temporary in order to have an extension, because I want him to get used to it, and he asked me how he will be with the final. So I decided, okay, we will make a new one, okay? But this is Daniel. The smile has changed. His attitude has changed. He's not scared anymore to come to us. And the main thing to us is that the bone level of the implant, it is good and solid, okay? And I know that if he takes good care of this situation, the treatment will last good. So he even come and take photos. We are all the time playing around, and he has become an ambassador from your clinic. This is the best marketing that we can have. That patient that knows that you have done the most that you have in your hands to help him. So 6 months later, he comes back, and then we see, he said to me that he stopped smoking. I said the picture doesn't say the same. But anyway, resin for me is not a final solution, especially for him. He's a young patient, he comes in and out, and I don't want to have problems, fractures or staining in this case. So we go to the final smile. This is the biggest start today. On the top, because we had an extension, we did a titanium bar. We have enough room, and then we cement the zirconia. And at the bottom, we work directly to the multi-units. Again, all the teeth that I did before, only 5 of the 148 arches had this titanium. The rest are like the bottom. Believe me, I'm not lying, okay? And I don't have the fracture on the connection, because yesterday a lot of people asked me, so I wanted to clarify, okay? So we have ultra polish, as Gallucci described. Make sure that you do a clean prosthesis that adapt to the tissues and the implants are in the right place, so this has to last on time. So when we analyze the finite elements, this is why we did the extension with titanium, because on the area of the premolar, it has an area where it's possible to have a fracture. So because we don't want fractures, then we did it this way. At the other hand, at the bottom, we have a nice and clean zirconia ready to be loaded for the bottom. And if you analyze the structure, it is good and there is no tension areas. This is the loading for Daniel. Nice occlusion, nice bite, tissues are adapting. He doesn't have a high smile, so we're good to go with that. So Daniel now comes to the office and he doesn't want to see, he doesn't recognize himself. Only in 3 appointments, apart from the new temporary, we have changed his life. And all because we have done a good project. We have done an easy step-by-step, okay? And this is where I think things should go. Now with the digital dentistry, for the new dentists that are coming, I think this is the way to work because we can analyze everything from the very beginning. So again, he plays around, he comes with my nurses, and this is his favorite photo to finish, okay? But to us, our favorite photos are this one. After a year, unscrew everything and see that the tissues stay the same, that there is no possibility, if he continues like this, to have a short problem in time, okay? The same thing happened at the bottom. Everything is nice and solid, and the hard tissues are good as well, okay? So this is the most important picture to me, to make sure that we have done parallel implants and we have done the promise that I did to Daniel, I accomplished. They don't know that they were going to be here, but when you have, they're not my parents. Some of you ask if they were my parents, but biologically it's not possible. They are not my bosses neither. In life, you choose family sometime, and to me, that's what they are. So thank you. And so I was lucky enough to start to work with them 10 years ago. And I think if you don't have somebody slightly older than you guiding you through a protocol, through a way of work, it's very difficult as a dentist to improve. So we always have to have a reference. And I think in this big community, you're always trying to do this, to have somebody who is just slightly more experienced than you, and there is nobody better than others, just more experienced than you. Also, today, this is my lover, can you say, or whoever, is Dr. Miguel Murua. I'm from the south of Spain, and he's from the north, and we, from this year, with MEGA'MIND Iberia, we train younger dentists to use R2Gate, to planify everything before, to not have mistakes. Why we have to have difficulties when we can avoid all that? Because if you have given the best, or then if there is any problem, you can justify your treatment, okay? And the philosophy is to say, just guide it. Guide your teeth. You need to be surrounded by your nurses, good nurses, technicians, good materials. But somebody has to be the director of all of this. You just have to guide everyone. And if you go on good music, make sure that you explain yourself to the rest that what you want to do with all the new technologies and everything. Okay? So ladies and gentlemen, I hope you like it, and thank you very much for everything.